Hello everyone, welcome to my video channel. Today I am going to talk about a summary of principles underlying total hip replacement for surgeons in training. I am quoting, this video is adapted from Understanding Primary Total Hip Arthroplasty by Alan Hammer, 1997, a part 1 video. As an introduction, the concept of replacing a diseased or destroyed hip with artificial components is reasonably sound, but after this, almost anything goes. However, in order to ensure a successful outcome with the specific prosthesis to be inserted, it is necessary to have a very good understanding of 1. Principle of construction of the hip involved, 2. The technique involved, and 3. Instrument to be used. Philosophies of the total hip design. The artificial hip replaces a previously functioning joint, and in doing so, is required both to move and to support the weight of the body. As it is a ball and socket joint, movement is generally not a major problem. However, in supporting the weight of the body, fairly large force are transmitted across it during movements, vertical stresses when the individual stands or walks, and rotatory stress when he or she sits, squats, or climbs the stairs. The components of the artificial hip have to be strong enough to withstand these forces and to transmit them to the bone of the pelvis above and the femur below. Attachment of the prosthesis can decide whether to use A. Cemented, B. Non-cemented prosthesis, or C. Hybrid, a mixture of the two. For A. Cemented hip, cement polymethyl methacrylate is an acrylic substance which serves as a reasonable filler between the bone and the prosthesis, insinuating itself into the spaces between the trabeculae and smoothly surrounding the prosthesis. Cement should be firm enough to support the force acting upon the prosthesis and flexible enough to lower the difference of the respective coefficient of elasticity. It has proved itself to be reasonably effective and durable agent for bonding the components to the bone. For cementation technique, after the introduction of methyl methacrylate cement, it was noted that some, if not many, of the hip prostheses loose in association with large erosions in the surrounding bone. This loosening was attributed to the breakdown products of the cement and is termed cement disease. Although these erosive bone lesions are now considered to be due largely to the wear of the acetabular cup, it is important to ensure that the cement fixation is as secure as possible. Certain techniques have been shown to enhance this. Number 1, the bone. The forces through the hip ultimately pass through the bone, and the larger and more intimate the contact between the cement and the bone, the more evenly they are distributed. Ideally, the bone should not be osteoporotic. Spaces filled with blood or fluid prevent the cement from surrounding the trabeculae, thus reducing their contact. The bone should be clean and dry. Simple irrigation to clean the space may be satisfactory. However, brushes assist during the washing up process, and if available, a pulsatile lavage system using a high pressure jet will leave the bone trabeculae white and pristine. Number 2, the cement. Polymethyl methacrylate is prepared from a powdered base and a liquid catalyst. The two mix together, polymerize and set with an exothermic reaction into a hard plastic material. During the early phase of polymerization, it is soft and moldable and ideally suited to fill the spaces between the prosthesis and bone. Different viscosities of cement are available to enhance its insinuation into the bone. The low viscosity cements are particularly necessary when using a cement guns with long nozzles. Methacrylate cement containing antibiotics, usually gentamicin, is available and is recommended for use in cases where there is a risk of infection. 1. Mixing of the cement. The strength of the cement depends on its uniformity of substance, and any spaces within it will weaken its structure. Air holes are a common phenomenon being introduced during the mixing. Whisking of the cement during mixing is to be discouraged. Gentle mixing is better. If available, special vacuum mixing dishes should be used. Number 2, pressurization. The cement should be introduced into the prepared bone cavities under pressure to squeeze it into the spaces between the trabeculae. This is sometimes difficult in the large acetabulum, but spherical expanding pressurizer may be available. In the femoral shaft, different pressure guns are available for introducing the cement. The guns may either have a long nozzle, allowing the cement to be introduced from the bottom of the prepared hole, or a short nozzle, allowing introduction from above. The long nozzle guns require extra cement to fill the nozzle, whereas the short nozzle guns need a vent tube to allow trapped air at the bottom to escape. Blocking the distal end of the prepared femoral medulla with a plug of bone or a cement restrictor aids the pressurization. Number 3. The cement mantle. Firm fixation of the prosthesis generally requires a complete shell of cement around it in both the femur and the acetabulum. There is, however, argument as to the thickness of which this mantle should be. Not less 2 mm and not more than 4 mm seems to be accepted norm. It is now important that the prosthesis is correctly placed in the bone, and some prosthetic stems have distal centralizers to ensure that it lies in the center of the cement. As illustrated, a distal centralizer. For the uncemented hip, attach directly to the bone without any intervening substance. Some prostheses are designed to achieve immediate mechanical fixation. On the acetabular side, this can be accomplished by using a screw-threaded rings, expanded cups, or cup fixated by screws into the pelvis. On the femoral side, this may be accomplished by femoral prosthesis being shaped so that it locks into the surrounding bone. The problem is that what level in the femur should this occur? As illustrated in the illustrated is the uncemented hip prosthesis. It is difficult to attach to distribute the forces evenly through the soft cancellous bone in the proximal femur and transmit the forces evenly through it. However, if the prosthesis is attached distally, there is the problem that the upper femur is shielded from the normal stresses acting upon it, and as a result, become weak and porotic. As illustrated, the Spotorno hip is an example of an uncemented hip fixed immediately by locking into the surrounding bone proximally. However, in the majority of uncemented prostheses, the aim is to obtain fixation of the implants by the ingrowth of tissue into the prosthesis. This latter form of fixation is biological bonding and the fixation is not immediate. The surface characteristics of this prosthesis are designed to encourage the surrounding bone to incorporate with it. In this respect, the material of the prosthesis is important, titanium being the most biocompatible. The illustration shows regarding the bone ingrowth to the prosthesis. Even under best circumstances, only 30% of the available area may be in intimate bonding contact with the bone. Attempts to improve one chance of a fix are made by increasing the surface area on the prosthetic surface, typically by texturing or coating the surface with various materials. Microlock and macrolock are terms which shows varying degree of surface roughness to allow an interlock between it and the surrounding bone. The greater the surface area is obtained by porous coating, that is sintering small metal beads or wires to the surface. Plasma spraying a layer of hydroxyapatite to the surface is a more reliable way of obtaining a firm molecular bond between the implant and the bone. As illustrated on the left-hand picture of the implant, a circumferential porous coating on the entire stem. Regarding the acetabular components, A. The cup materials. The original total hip arthroplasty had a metal heads and metal cups, about the diameter of the normal femoral head. While many of these did well, there were cases of loosening. It was attributed to friction between the large components. Sir John Chanley introduced the concept of low friction arthroplasty. Initially, using a Teflon cup and a small head diameter, he showed that the friction between the two components could be considerably reduced. The Teflon, however, wore very rapidly and he changed the material to polyethylene. Despite this, there is still a regular amount of wear of the articular surface of the cup, particularly when using a metal femoral head. The wear particles generated from this cup have been shown to be a potent cause for the massive osteolysis, which is often associated with loosening of the components. Other materials are now being used to try to tackle this problem. One method is to make harder, more wear-resistant plastic. Ceramic on ceramic gives an articulation with very low friction, but is very hard on the bone. Modern metal on metal articulation appears promising for a low friction and longevity, but is extremely expensive. The best compromise at present is to use a ceramic femoral head with a polyethylene cup. As illustrated, there is a large number of hip implant devices on the market. Each style falls into one of four basic material categories: metal on plastic, whereby polyethylene or ultra-high molecular weight polyethylene UHMWPE, metal on metal MOM, ceramic on plastic, ultra-high molecular weight polyethylene UHMWPE, ceramic on ceramic COC. B. The cup shape. The acetabular component is always cup-shaped in its inner aspect but may take one of the variety of shape into on its outer aspect. The cemented acetabular cup generally has a variety of cross-hatchings on its outer surface to enhance the grip of the metacrylate cement. Uncemented acetabular cups shows a much wider variety of methods in an attempt to obtain a solid purchase to the underlying bone. As illustrated, polyethylene liner is the most common material type for the acetabular liner. However, ceramic or metal are also available. The acetabular shell provides the base for bony ingrowth, while the inner clips into the shell and articulate directly with the femoral head. Uncemented acetabular cups shows a much wider variety of methods in an attempt to obtain a solid purchase to the underlying bone. These include coating the polyethylene with hydroxyapatite or titanium crystal, or using some form of metal backing which attach to the bone by way of screw threads, porous coating, expanding plates, wire mesh, and or simple screws. As illustrated, cementless acetabular cup system. For the femoral components, there are more arguments as to the material composition, the configuration, and the surface texture of the femoral prosthesis than of the acetabular components. Classically, the femoral component is thick with smooth corners and more or less parallel sides to its stem. With this type of hip, there was a relatively high incidence of loosening. In order to accommodate a creep, fracture, and other distortion of the cement mantle, the femoral stem should be smooth and tapered to allow it to settle within the cement and maintain its stability. As illustrated, a tapered neck. If the loaded prosthesis tends to subside within the femoral medulla, it generates a hoop stresses in the cement mantle. As the medulla tends to widen from a variety of factors, example aging, cement disease or polyethylene disease, and simple mechanical loosening of the prosthesis, the outer support is lost and these hook forces tend to hasten the degradation and disintegration of cement. As illustrated, hoop stresses versus the compressive stress. The stem should be fixed firmly into the cement to prevent subsidence. Stem designs are a rough surface and may also have a layer of polymethyl metacrylate bonded to its surface to enhance the fixation to the cement. As illustrated, figure shows a variety of cementless stems. Regarding the collar of the femoral components, the idea of a collar is that it supports the load on the femoral neck and prevents subsidence of the prosthesis. Its position places the load on top of the femur rather than lower down, as is the case with non-collared or collarless prosthesis. The problem is that the neck of the femur must be cut accurately to match the collar, otherwise it may not be effective and cause toggling of the stem. As illustrated, the figure shows a collar prosthesis. Yay! That's all for today. I hope you have learned something from this video. See you in the next one. Take care and bye.